linear deposit of IgG along the capillary walls. So some amount of IgM was negative, however, C3 was also present. So percentage of crescents are more than 90%. This gives a high positive predictive value. Monomorphism of crescents. Most of the crescents are in the same chronological age. We find most of the crescents are almost similar. So that means they have been progressing together in the time frame. Then we can see multinucleate giant cell reaction around the glomerulus in some subset of cases. And these are the cases which can confuse us with GPA. Even in GPA, we can have granulomas and we can have giant cells. Then we come to post-immune crescentic glomerulonephritis. So these are the necrotizing small vessel vasculitis, and they are either P ANCA or C ANCA positive. Now, ANCA has been discussed at length, and I won't be going into the ANCA findings or the ANCA morphology. What we find again in these cases are extensive fibrinoid necrosis. Previously, we were finding orderly crescents. But as we move into small vessel vasculitis, we find that the crescents become disordered. And here the finding is that the Bowman's capsule is destroyed. Then there may be a periglomerular granulomatous reaction with or without giant cells. So these giant cells usually we may see in cases of GPA, which was earlier known as vaginous granulomatosis. This is a clue. There may be absence of proliferative lesions, and there is absence of significant immunofluorescence or EM findings. If you are finding a crescent with a proliferative lesion, think of either lupus or think of IgA nephropathy. I'll show you once I start showing you my cases. So we can have a microscopic polyangiitis, which is quite common in Asia. We can have GPA or vaginous granulomatosis, which is more common in the Caucasians. We can have EGPA or the Schuch-Strauss syndrome, which are eosinophil rich. And this can involve only in up to 60 to 70% of the kidneys. Otherwise, both the microscopic MPA and GPA, they involve almost 80 to 90% of the kidneys. So renal manifestation is less in cases of Schuch-Strauss. So this is how the complements are activated. We have these neutrophils which are expressing their MPO and PR3 on the surface, bound to antibodies, and these release the complement activating factors, the factor B, D, and properdine. The alternate pathway is activated. We have the complement cascade, and they go and finally further amplify the damage. So that is how the vascular endothelial cell is damaged, and these cause vasculitis and crescent formation. So these are already discussed. I'll just skip so that I can show you more lesions. This has already been shown by Shubhra, all the skin manifestations. And of course, I've told you about the pulmonary manifestations. Even we find cases referred to us from ENT, but the biggest contributor is rheumatology and nephrology. So there can be drug-induced vasculitis also, especially propylthiouracil and methimazole, carbimazole, hydralazine, minocycline. These are less common. However, still we can have drug-induced ANCA vasculitis. So this is from one of my cases of microscopic polyangiitis, where you can find that this is the Bowman's capsule. This is ruptured at places, and there is a kind of a giant cell formation here. And what we find is that these capillaries, they have broken down, and they have formed fibrin here, and these podocytes, they have started proliferating. So in subsequent sections, we found some crescents, and this was a case of MPA. This is another section where we took several cuts, and usually when I see a kidney biopsy, I take around 16 to 20 cuts from a single core, so that I study it at different levels, what's known as the Z-axis. So once you go from polar to polar sections, you find that the morphology changes, and that's how you should evaluate a kidney. You should look for you should look in all the 4 compartments with all the 4 stents. And here we started finding the crescents, which had become sclerotic at places. So this is the Mason's trichome stain, the tubular interstitial compartment, which showed a lot of inflammation, and extraglomerular necrotizing lesions were also found. In one case, we found a bit of medullary angiitis also. Otherwise, the interstitium is usually studded with lymphocytes and neutrophils. So these are the differential features in post-immune crescentic GN. Renal disease, as I said, MPA we have the highest involvement, and EGPA we have 45 to 50% of the kidneys they are involved in EGPA. And these are the different serologies. So I'll try to rush up as I just have 2 minutes left. What we find here is that there is no proliferation of tufts. As I had mentioned, immune complex deposition may be absent, is usually absent in cases of immune complex CGN, fibrinoid necrosis, post-immune and anti-GBM, you have a lot of fibrinoid necrosis. Whereas in immune complex CGN, you may or may not have extensive fibrinoid necrosis. So that's what we try to pick up. So 75% they go into remission, and 30% they may relapse. So that is why it's important to follow up the patients. So when to suspect ANCA crescentic GN? Once we see the crescents, we find that these crescents are pleomorphic. That is, they have different appearances. So that means they are evolving over a time. Then uninvolved tufts, the glomeruli are non-proliferative. As I've said, in proliferative lesions, we suspect lupus and IgA nephropathy. Then predominance of plasma cell infiltrates with or without granuloma. Transmural necrotizing arthritis. And of course, we have the whole serology to support us, the ANCA serology. But the key diagnostic help is by immunofluorescence. So we can have various combos. How to sign out total number of glomeruli in the core, glomeruli affected by crescents, the glomerular tuft, necrotizing lesions, percentage, tubular interstitial findings, and vessels. I'll just quickly rush through. This was one case of cryoglobulinic vasculitis, where we found deposits of cryoglobulin in an elderly male who presented to us with leg ulcers, atypical features of cryoglobulin. He was found to be hepatitis C positive. This is IgM stain which I did, and you can see the deposits of cryoglobulin in the glomerular tufts, and we found some fibrils for the electron microscopy which we had sent to an outside lab. Then we had this child, just a couple of slides more, please bear with me. We had this child 2 months ago who presented, who was a 8-year-old post-varicella zoster case who presented to us with hematuria. Initially, hematuria was not there, so we wanted to wait and see the renal involvement. The moment hematuria was there, we did a biopsy, and the biopsy showed a bit of proliferative MPGN cauliflower-like appearance. And what we found in the immunofluorescence was almost 3 to 4 plus positive IgA in the mesangium. So CTD with small vessel vasculitis, we can see in lupus, rheumatoid arthritis, and Sjogren's syndrome. And lupus vasculopathy has been dealt with extensively yesterday by Sanita ma'am. And here we had a 29-year-old female just last month who presented to us with malar rash, arthralgia, and hematuria, whom we biopsied, and we found a class 4 lupus with diffuse proliferation and MPGN kind of a picture with these hyaline deposits. So she was treated accordingly, and in other sections we even found crescents. So these are bad prognostic factors, and we have this scoring system where we assign a score, activity and chronicity score. She had a very high activity score and a chronicity score of 2 by 12. So she was treated accordingly. Rheumatoid arthritis, I have seen a few cases with. This was one case where we found almost a normal glomerulus. But when we did the IF, we found it to be membranous nephropathy, where we found strong IgG positive in an epimembranous fashion. So this was a case which was involved by rheumatoid arthritis, and another case which showed necrosis and crescent formation. Again, they can lead to vasculitis. Sjogren's syndrome, I have not seen any case till now of renal involvement. Then medium vessel vasculitis, Kawasaki's disease does not usually involve the kidneys, so we are relatively free of that. Large vessel vasculitis usually don't affect the kidneys, but they can affect the vessels, and these vessels can have a constrictive effect, and they can show a sclerosis of the vessels with a hypertension kind of an image. So to conclude, just to summarize this whole slide in one sentence, together we can. We need a good clinical history, a support by serology, and of course a good biopsy, and a knowledgeable mind to look into that biopsy, and we can offer our best to the patient, which we must try in any case. So thank you so much. I'm sorry I overshot by a minute or so, and this is a lovely hospital where I work. And just a small announcement, next Saturday, we are organizing the APMWB monthly meet. Please come. We had a request from all the HODs that we should teach autopsy pathology to the students. So we have dedicated this to study of autopsy pathology. So we'll be teaching how to do autopsy. Then we have a very interesting CPC where we'll show a lot of different histologically fascinating features. I mean, a lot of diseases combined in one individual. And I hope the PGs will enjoy it. And of course, followed by a hematology quiz. So please come, all of you, and do let us know whether you're coming or not, so that we can prepare accordingly. And thank you once again to everyone for inviting me, for listening to me patiently, and have a nice day. Any questions I'd like to take?
Any questions? It was a very, very good and elaborate presentation.
Thank you.
Thank you very much.
Paula sir, will you please felicitate Colonel Dr. Prashant
I have one question. Colonel Sengupta,
Yeah.
most of the cases you have shown that in renal manifestations we are doing PA stain as well as immunofluorescence stain. But suppose in case we cannot go for direct immunofluorescence, what special stains do you recommend apart from PA stain, so that we can come to a relatively accurate diagnosis?
See, that's an excellent question, because everybody may not be having immunofluorescence with them. But let me tell you that immunofluorescence is mandatory for a renal, because if IgA is there, it may give you a PS positivity. But that can come in SLE also, that can come in so many other things. You may not be able to pinpoint that it's IgA. So in our lab, what we do, apart from direct immunofluorescence, we have developed a method of proteinase K digestion or pronase K digestion, and doing immunofluorescence on paraffin-embedded tissues also. So if our cryostat is not working, then what we do is we digest it with proteinase K, we express out the antigens, we do an immunofluorescence, and we study. And now we are correlating, our results are coming very well. So we really cannot do away with the immunofluorescence. We have to do it to come to a diagnosis.
Thank you. Any more questions? If there are no questions, we conclude the talk.
Sir, please felicitate. Thank you so much, sir. Our next speaker is Dr. Soutrik Das. Dr. Soutrik Das, please come. The topic is on vasculitis neurological manifestations. On behalf of CAP, I welcome Dr. Soutrik Das.
A very good morning, everyone. I'd like to thank respected chairpersons and also to the organizing committee of CAPCON for inviting me here to present on neurological manifestations of vasculitis. I am going to speak about CNS and PNS vasculitis with their clinical manifestations, followed by a brief discussion about individual conditions with some important histologic correlates. Finally, role of nerve biopsy in diagnosis of vasculitic neuropathy. Let's start with CNS vasculitis. CNS vasculitis are challenging to clinicians in many ways in terms of their highly variable symptoms, difficulty in establishing a correct diagnosis, often due to a limited scope of histologic confirmation, variable response to therapy, and frequently poor outcome. They can be classified broadly etiological into non-infective and infective conditions. Non-infective vasculitis include primary cranial or cerebral vasculitis and secondary vasculitis due to some systemic disease. Among primary conditions, the most common ones are giant cell arteritis and primary angiitis of CNS. There can be Takayasu or beta amyloid related angiitis. Secondary causes include PAN or ANCA-associated vasculitis and various types of connective tissue diseases. Certain infections, bacterial, viral, fungal, protozoal, and other infections can also present with vasculitis. So what are the clinical manifestations of CNS vasculitis? CNS vasculitis have diverse symptomatology. Most commonly patients present with headache. There can be also stroke, seizure, cranial nerve palsy, various psychiatric syndromes, dementia, etc. Let's start with primary cranial or cerebral vasculitis. There are four main types: Takayasu arteritis, giant cell arteritis, primary angiitis of CNS, and beta amyloid related angiitis. Interestingly, all of them are characterized histologically by granulomatous angiitis. Giant cell arteritis is the most common one among them, and usually occurs in elderly patients above 55 years of age, targets principally extracranial arteries of head and neck, especially superficial temporal arteries, which appear as tortuous, thick and tender vessels with reduced pulsations. GCA is commonly associated with polymyalgia rheumatica and high ESR, and patients usually respond promptly to steroids in most cases. The common presentation is headache followed by blindness due to affected ophthalmic artery or occipital infarct, which can be secondary to embolization from a thrombosed vertebral artery. Permanent blindness can be seen in 8%, stroke or transient ischemic attack due to rare involvement of carotid or vertebral artery. In the autopsy specimen here, we can see cerebellar infarct due to vertebral artery occlusion. Peripheral neuropathy can be there in 14% patients, and that may even precede the diagnosis by several months. There is cell-mediated immunity to unknown antigen. Inflammation can be focal, so a biopsy of 3 to 5 centimeter length is recommended. As the name suggests, it is characterized by presence of giant cells, usually foreign body or Langerhans type of giant cells. Histology shows the intimal hyperplasia here, dense infiltrates in media and adventitia, loss or disruption of internal elastic lamina as highlighted by elastin stain here. And we can see here a row of giant cells, usually in the media, with luminal narrowing. Complications include aneurysm and thromboembolism. Remember, lack of giant cells in biopsy does not rule out a diagnosis of GCA. Next is primary angiitis of CNS. It is a rare disease of unknown etiology, can affect children, young adults, or middle-aged persons. ESR is only mildly elevated compared to GCA. Angiography can show multiple narrow segments in cerebral arteries. Here in the MR angiogram, we can see a stenotic proximal segment of left middle cerebral artery, and the corresponding FLAIR image shows the chronic type of infarct in the left MCA territory. MRI can also show hemorrhage or distinct type of white matter lesions. As in this MRI, we can see the multiple punctate foci of contrast enhancement in deep white matter and periventricular location. Outcome is variable. They can vary greatly from spontaneous resolution to rapid decline or even death. Aggressive immunosuppression is usually needed to treat these patients. Arteries are more affected than veins. An ideal sample would be a biopsy, which include leptomeninges and a cortical wedge. Histologically, we can get granulomatous vasculitis or perivascular lymphocytic infiltrate, or even a pan-like necrotizing vasculitis. Here also, a negative biopsy does not rule out PSCNS. Next is beta amyloid related angiitis, which occurs in some patients with cerebral amyloid angiopathy. Angiographic findings and vessel distribution are similar to PSCNS, but they occur in older age group. Patients usually present with rapidly progressive dementia or hallucinations. Discrete white matter lesions are seen. Histologically characterized by necrotizing angiitis or granulomatous inflammation. Here, as in this picture, we can highlight the beta amyloid using the Congo red stain. Takayasu arteritis, it is not a pure CNS vasculitis per se. In Takayasu, there is inflammation of aortic arch with its main arterial trunks and descending aorta. The CNS is affected when the carotid arteries or their branches are involved. Usually occurs in young patients with a predilection for Japanese females. Angiography can show variable involvement of subclavian, carotid, coronary, and renal artery. There is loss of compliance of vessel walls leading to absent or weak pulse, hence the name pulseless disease. Cerebral ischemia occurs secondary to embolism. Histology is similar to giant cell arteritis with dense infiltrates, often giant cell reach in the media and adventitia with fibrinoid necrosis of wall and disruption of internal elastic lamina. Kawasaki's disease is a rare mucocutaneous lymph node syndrome of unknown etiology, mostly occurs in children younger than 5 years of age, characterized by fever, lymphadenopathy, rash, edema, mucositis, cardiac symptoms, etc. There is necrotizing arteritis involving large, medium, and small arteries. CNS involvement leads to cerebral hypoperfusion, stroke, or diffuse encephalopathy. Behçet syndrome is another rare multisystem vasculitis of unclear pathogenesis, characterized by recurrent ulcers of oral and genital mucosa, uveitis, arthritis, and various types of skin lesions. CNS involvement is quite common, seen in 30 to 40% patients. Neurobehçets usually present with meningoencephalitis or rhomboencephalitis. Cascade sign is a hallmark radiological feature. It occurs when the mesodiencephalic region is affected. It is basically an irregular zone of hyperintensity which extends from thalamus and internal capsule caudally to the midbrain. There is predominantly affection of large veins and arteries with often pseudoaneurysm formation. Drug-induced vasculitis in CNS, it can be seen in abusers of cocaine or amphetamine. Necrotizing vasculitis is usually seen. Coming to some infective causes, bacterial vasculitis, common in pneumococcal and tuberculous meningitis, can affect small and large arteries, leading to cerebral infarcts. This is autopsy specimen from a tuberculous meningitis. We can see a large area of infarct in the right MCA territory. Histology shows dense lymphocytic infiltration in the wall of middle cerebral artery. Spirochetal vasculitis should be mentioned separately. Particularly in meningovascular neurosyphilis, treponema usually inverts arterial wall, leading to Huebner's arteritis, which is characterized by intimal and adventitial thickening, dense infiltrations of lymphocytes and plasma cells in the adventitia. There is thinning of media and duplication of internal elastic lamina. In Lyme's disease due to Borrelia, vasculitis is also common. Vasculitis is also reported in patients with herpes virus infection, most commonly with varicella zoster. There can be lymphocytic, necrotizing, or granulomatous vasculitis. This is from a patient who had a past history of ophthalmic zoster. We can see fibrinoid necrosis and lymphocytic infiltrates in the wall of posterior cerebral artery. In the same patient, below, we can see necrotizing vasculitis and large infect in basal ganglia. HIV can be associated with certain types of vasculitis, PSCNS and pan-like conditions, hypersensitive vasculitis, or lymphomatoid granulomatosis. Vasculitis is quite common in infections due to Aspergillus mucor candida. Fungal emboli may lodge in intracranial arteries, penetrate the wall, and can induce vasculitis. Complications include thrombosis and infarcts, vessel wall rupture secondary to aneurysm, and hemorrhage. In this patient of cerebral aspergillosis, we can see a large necrotic area in the right frontal lobe. Histology shows large area of necrosis with a thrombosed blood vessel. GMS10 highlights the fungal hyphae. Now coming to PNS vasculitis, the vasculitis in peripheral nervous system can be confined to peripheral nerves, then it is called isolated PNS vasculitis, or it can be a part of a systemic disease. Usual secondary causes are a primary systemic vasculitis like PAN or ANCA-associated vasculitis, secondary to some connective tissue disorders, commonly rheumatoid arthritis and Sjogren's syndrome, certain infections, and among other causes, paraneoplastic is important. Musculitic neuropathy most commonly presents as mononeuritis multiplex followed by distal symmetric polyneuropathy. Other manifestations can be asymmetric polyneuropathy, radiculoplexopathy, or pure sensory ataxia. Isolated PNS vasculitis or non-systemic vasculitic neuropathy, where only vasculitis is confined to peripheral nerves only, they comprise about 1/4 of the all cases of vasculitic neuropathy. Concurrent vasculitis may be found in muscle biopsy. Though the name suggests that it's confined to peripheral nerves, it should be considered a low-grade systemic vasculitis, which is symptomatic in nerves only for the time being because of increased vulnerability of nerve tissues to microvascular insults. PAN or polyarteritis nodosa is a prototype of necrotizing vasculitis already discussed, and it usually involves medium and small arteries, often associated with hepatitis B or C infection. There are two different forms of PAN, systemic and limited. The peripheral nerves, CNS and skeletal muscles are usually involved in the limited form of PAN. CNS involvement is the second most common death in PAN. ANCA-associated vasculitis are essentially small vessel vasculitis. There are three well-known conditions. Oegenous granulomatosis or granulomatosis with polyangiitis shows focal necrotizing or granulomatous vasculitis in lungs or other sites associated with CANCA, commonly anti-PR3. Primary neurological manifestation is seen in 30% of patients. Peripheral neuropathy can be seen in 10 to 20% patients. Churg-Strauss syndrome or eosinophilic granulomatosis with polyangiitis associated with PANCA or anti-MPO. Histologically characterized by eosinophil-rich inflammatory infiltrates and extravascular necrotizing granuloma. CNS involvement leads to stroke or ischemic optic neuropathy. Peripheral nerves are commonly involved. Peripheral neuropathy can be seen in 20 to 60% according to various series. SLE frequently involves CNS, about 75% of patients. Neuropsychiatric SLE presents with stroke, seizure, psychosis, or depression. Peripheral neuropathy can also be seen in 10 to 20% cases of SLE. Regarding vascular involvement in SLE, there are two hypotheses, vasculitic and thrombotic hypothesis. According to vasculitic hypothesis, there is primarily small vessel inflammation, deposition of immunoglobulin or complement, or leukocytoclastic vasculitis. According to thrombotic hypothesis, thrombosis and embolism is the main pathology. There is limited vascular pathology, and the thrombosis is the more important contributor to CNS damage than the vasculitis itself. Sjogren's syndrome can be primary or secondary. Vasculitis is seen in 10 to 15% of primary Sjogren's. There is necrotizing vasculitis of medium-sized vessels. PNS involvement is quite common, and patients usually present with distal sensorimotor neuropathy or pure sensory neuropathy when the dorsal root ganglia are involved. CNS vasculitis predominantly affects small veins in white matter. Rheumatoid arthritis rarely involves intracranial vessels. There are only a few reported cases. This is one such case where the left temporal lobe swell was there. Vasculitic neuropathy is common and can occur after many years of active disease, but vasculitis in RA indicates poor prognosis. Mild sensory neuropathy is the most common presentation. There can be entrapment neuropathy. Progressive multifocal neuropathy is the most devastating form. Among paraneoplastic causes, the hematological malignancies are most commonly associated with vasculitic neuropathy. Now coming to the role of nerve biopsy. Nerve biopsy is critical for diagnosis of vasculitis when there is isolated vasculitis of PNS or a systemic vasculitis presents atypically as a cryptogenic polyneuropathy. Epineural vessels are involved much more frequently than the endoneurial vessels, so fascicular biopsy is strongly discouraged, which often misses the epineural pathology. If muscle biopsy can be added together, yield may increase up to an additional 15 to 45% patients. Findings are often focal or patchy, so step sections may be necessary. Also, optimal length is required, at least 2 centimeter. 2 centimeter is called the optimal length, but it should not be less than 1.5 centimeter. Perivascular inflammation is not equal to vasculitis. So when can we call vasculitis in case of nerve biopsy? According to modified Collins criteria, definite vasculitis is defined as the presence of transmural inflammation with evidence of acute or chronic vascular damage. When there is perivascular inflammation but not transmural inflammation with signs of active or chronic vessel wall damage and predominant axonal changes, we call it probable vasculitis. Possible vasculitis means either there is lack of inflammation or there is lack of any evidence of vessel wall damage. In any case, the vasculitis usually shows thrombosis and there is vessel wall occlusion leading to a ischemic pathology, ischemic injury to nerve tissue, leading to axonal degeneration. So we get primarily axonopathy in case of vasculitic neuropathy. What are the signs of acute vascular damage? Fibrinoid necrosis, this is from one of our cases. Fibrinoid necrosis, loss or disruption of endothelium and internal elastic lamina. Also acute thrombosis, vessel wall hemorrhage, leukocytoclasia, and in nerve biopsy, we get the myelin ovoids as an evidence of acute axonal degeneration. Signs of chronic vascular damage include intimal hyperplasia, medial or adventitial fibrosis, here vessel wall sclerosis, and chronic thrombosis with recanalization, and periadventitial hemosiderin-laden macrophages, which can be highlighted by Pearl stain. What informations do we get from myelin stain? Often there is no inflammation in the nerve biopsy. We have to confess something. So there are some hints to vasculitic neuropathy. Myelin is routinely assessed on nerve biopsy using the K-Pearl or Kulczycki-Pearl stain. It shows multifocal non-uniform fiber loss with great intrafascicular and interfascicular variability of fiber loss. Usually centrofascicular loss or perineurial based wedge-shaped loss as highlighted here using the neurofilament IHC. Initially selective loss of large myelated fibers, gradually loss of all fiber types. In recovery phase, we get regenerating clusters as highlighted here, which mean presence of 3 or more axonal sprouts together within a single basement membrane of Schwann cell. This is a semithin section stained by toluidine blue and shows several regenerating clusters. Segmental demyelination can also occur. So finally, what are the take-home messages? No specific symptom for CNS or PNS vasculitis. Clinical presentation depends largely on the location and caliber of the affected vessels. Most of the primary intracranial vasculitis are granulomatous angiitis. PAN, ANCA-related vasculitis, and RA are the major causes of secondary vasculitic neuropathy. It is most often a patchy or focal process, though there is limited scope for brain biopsy for vasculitis, but it can be confirmed easily using peripheral nerve biopsy, and open biopsy is recommended. Definite vasculitis is defined by the presence of transmural inflammation, and vasculitis results in ischemic damage to nerve fibers, leading to axonopathy. Thank you.
Thank you, Dr. Soutrik, for an excellent on-time presentation. Now the talk is open to the audience. Any questions from the audience, please?
Yes, ma'am. Yes, ma'am.
In fact, this question is to everybody. The granulomatous inflammation, is it just a group of histiocytes, or do you really have to show epithelioid cells?
No, we take granuloma means collection of epithelioid cells, classically at least 6 or more epithelioid cells. So if there is definite granuloma in the vessel wall, then only we can call it granulomatous vasculitis. But mostly we do not get.
Yes,
I have not
it's
seen
difficult to
myself.
demonstrate
Very
that,
difficult,
isn't it?
yeah.
One question from me. In case of intracranial biopsy, what images do you prefer? Is it a contrast-enhanced MRI or any other type of image for stereotactic biopsy for intracranial lesions?
Sir, first of all, the intracranial biopsy, frequency is very rare. I have seen only a few. Intracranial biopsy is rarely done here for vasculitis, non-tumor conditions. But usually for vasculitis, with contrast, of course, with contrast, MRI with contrast is necessary. And also the FLAIR image, usually all are done before doing biopsy.
Okay.
Request Dr.
Thank
Ponash
you.
to please felicitate Dr. Soutrik. A big round of applause, please. Ma'am, if you could please felicitate. Thank you, Dr. Soutrik Dash, for the very illuminating talk. We would be glad to call Dr. Priyankar Pal on stage for his session on overview of autoimmune disease in pediatric population. Dr. Pal, please.
Big thanks to the organizers for keeping the children in mind. So we all know that children are not miniature adults, and of course, data of the adults cannot be extrapolated for the children. So over the next 15 minutes or so, I will take you, we'll just have a sneak view at the fascinating world of pediatric autoimmune diseases, starting with the father of all rheumatic diseases, that is rheumatic fever. We will bypass the world of developing world of inflammasomes and the autoinflammatory fevers, and finally we will have a look at the very interesting world of cytokine storm syndromes. So that is Duckett Jones, the father of rheumatic fever. You can see in the 1940s, he laid down the Duckett-Jones criteria for diagnosis of rheumatic fever. So after several revisions, this was one of the last revisions, 2015 revisions, rheumatic fever has definitely gone down. So with the presence of antibiotics for the last 100 years or so, definitely we are seeing much less of rheumatic fevers than we used to see maybe 20, 30 years back. And one must remember that the arthritis of rheumatic fever is usually in the large joints. The small joints and the axial skeleton is definitely spared. And it runs a self-limited course. Even without treatment, they should subside by the next 4 weeks from onset. So, although we are fascinated by this, that a sore throat can lead to a broken heart, and still we get a lot of referrals because of ASO. So, isolated ASO elevation in an otherwise asymptomatic child, or a child presenting with some non-specific arthralgia. Definitely it is not rheumatic fever. We know that children, they go on getting streptococcal infections, and definitely that is the reason for the ASO elevation. And ASO elevation is not equivalent to rheumatic fever and neither a subsequent heart disease. So rheumatic fever, we all knew, was the most important cause of acquired heart disease till this man came into the picture with his 1967 publication on infantile acute mucocutaneous lymph node syndrome, a clinical observation of 50 cases, which was published in the Japanese Journal of Allergy. So Kawasaki disease by no means is a rare entity. It is the commonest cause of acquired heart disease. It has replaced rheumatic fever, and it is also the commonest cause of pediatric vasculitis. And diagnosis of Kawasaki, the classic Kawasaki, is based on certain clinical features, which on itself, if you look at the clinical features individually, they do not carry any significance, but if you look them as a whole, then it becomes important. So if you look at the pathognomic clinical signs, a child presenting with fever, usually a young child, 2 years, 3 years, usually not more than 5 years. There can be definitely reports of Kawasaki disease in adolescents as well as in adults, but usually it's a disease of the young age group. So a child presenting with fever and non-suppurative bulbar conjunctivitis. The eyes are red, but there's no discharge. The child may be very irritable. The lips. So if you look at the lips are dry, red, erythematous, sometimes parched lips. And that is one of the distinctions from scarlet fever, because scarlet is, the tongue is usually involved, but the lips are usually spared. So these are the classic lips of Kawasaki. You can have a rash, any form of rash, except a vesicular rash or a bullous rash. And then the unexplained edema of the extremities, a cervical lymph node, usually not tender, but sometimes you can have something resembling a suppurative lymphadenitis. And this is one of the very characteristic